testing, followed by a case presentation, and then a presentation by our esteemed guest speaker, Professor Sudhir Rawal, and followed by a question answer session, and then a quiz competition, comment from the faculty member, and the brief summary and the take-home message of the day. Please put your question in the chat box. Your each and every questions will be answered. We are delighted to introduce Professor Abdul Salam, a distinguished oncologist and esteemed authority in the field of oncology in the field of urology in our country. Professor Salam has dedicated his career to the study, diagnosis, and the treatment of the urological condition, with a special focus on the prostate, renal, and the testicular cancer. And I am welcoming everybody to our today's webinar. Welcome all. So first, there will be a polling and on renal tumor. So we'll have to see the basic understanding and existing knowledge of our postgraduate students. The polling will be moderated by Dr. Nurul Amin Bhuiya, consultant surgery. Dr. Nurul Amin Bhuiya, please come to the screen and conduct the poll.
Thank you, sir. So please share the.
So our patient, Mr. X, 65 years old farmer, presented with a painless total episodic hematuria for last 3 months. Hematuria occurred for several episodes, and each episode continued for 1 to 2 days and then got relieved spontaneously. He also gives history of passage of clots in the urine, and he also had an episode of acute retention of urine, which was relieved by urinary catheterization and some procedures through the urinary tract in a local hospital. It was associated with dull aching, continuous right loin pain with no radiation, no aggravating and relieving factor. He has anorexia and weight loss, but he couldn't mention the amount of weight loss, and also gives history of 5 units blood transfusion in last 3 months. There is no history of fever, any fever with chills and rigor, any burning sensation in micturition, night sweat, evening rise of temperature, renal trauma, any known bleeding disorder, or history of taking any drug. He has no cough, hemoptysis, chest pain, bone pain, jaundice. He is normotensive, non-diabetic, and non-asthmatic, having no significant past illness and family history. He is a smoker and has smoked about 15 sticks per day since last 20 years. On examination, he appears ill and undernourished with a BMI of 17.7 kg per meter square and ECOG performance score status is 1. He had a tri-channel urinary catheter in situ connected to a closed drainage system. There was no anemia, jaundice, edema, or dehydration, and his vital signs were all within normal limit. Examination of genitourinary system along with digital rectal examination revealed no abnormality. Abdominal examination revealed no ascites or organomegaly, and other systemic examination findings were normal.
Yes, thank you. Yes.
So according to the case, my provisional diagnosis is bladder neoplasm with clot retention.
Thank you, Dr. Amina, for presenting the case.
Thank you, sir.
Professor Mojid. Sir, can you hear me?
I think she has presented the case quite well.
Thank you, sir.
Thank you, sir. Professor Margoof, sir, any comments, sir?
I agree, excepting one point.
Yes, sir.
It is not urinary catheterization, it is a urethral catheterization.
Okay, sir. Yes.
Thank you, sir. Rightly mentioned.
Thank you, sir.
Thank you, sir. Yes.
And also that she was telling about that catheterization just at the time of presentation or at the time of general examination. Why in the
general examination?
You could put it in the genitourinary system in that way, that I've examined the kidney, the bladder, and then DRE, and he has got a prostate, that is a catheter in situ, vaginal porous catheter. That would be better presentation.
Okay, sir. Thank you, sir.
Okay, sir. Professor Salam, have you joined? Not yet, I think. Professor Sudhir Rawal.
Yes. Yes, sir.
And, what do you think about her presentations?
No, she did quite elaborate, only then 2-3 things which Dr. Hussain mentioned. It's not urinary catheter, it's urethral catheter, but she, if actually, when it is like they are medical students, so they have to tell about DRE finding in detail. One has to see on a examination that there is no lump palpable, bladder is not full, not clot. You know, if there is a clot, bladder can be full with the catheter even. So those are the few things, but then she has done very well in mentioning about no cough, hemoptysis, pain, jaundice. So that's quite well presented case she has done.
Okay, then
The
thank you.
examination probably
Thank you.
I'll go in more detail. That's it.
Yes. Okay. So now you can proceed, Professor Sudhir. You can ask question to Dr. Amina.
No, she has said urinary bladder. Her diagnosis is urinary bladder. I'd like to ask her why she says that it is urinary bladder tumor. Why can't it be any other tumor like kidney? From kidney per se, they can cause hematuria.
Yes, sir. Yes, sir. My differential diagnosis will be the renal neoplasms. But as the patient presented with painless hematuria, and along with it, there was a history of clot retention, and there was also a history of acute retention and passage of the clots. These go more in favor of the bladder neoplasm. And also he has the smoking history, which increases risk of the bladder neoplasm.
Yeah, first diagnosis is this, but then it can be kidney tumor.
It can be renal neoplasms too.
Yes, it can be upper tract urinary
Upper tract urinary, yes.
And whenever hematuria is there, here it was gross with clots and all. If suppose mild hematuria, if the patient is coming with first time he has passed, urethral hemorrhage or initial. One thing that you have to differentiate hematuria with the initial or total or painless or painful. Painless you said already, but then you have to take the history of blood thinner also.
Yes, sir. There was no history of taking any drugs, any anticoagulants.
Great.
Well, just one thing you mentioned that the hematuria is total. That I clearly remember from your history. And total hematuria does not usually occur in a bladder neoplasm. It's usually terminal hematuria. Total hematuria is suggestive of a neoplasm in the upper tract. That has to be borne in mind. Thank you.
Yes, sir. Thank you.
Okay, this was about this history presentation and the rationality of this diagnosis. And then we switch over to investigations.
Dr. Salam is here. I would like to have some comment regarding the presentation of the bladder neoplasm.
Yes, sir.
As has been stated many times, we found that asymptomatic bladder neoplasm cases, they are detected incidentally by other investigations. Say for any other reason, the ultrasound is being done, maybe picked up, or in a CT scan, a suspicion was made for a bladder neoplasm, a filling defect. So this is number one. Number two, the hematuria may be of different kind, depending on the size of the lesion, the aggressiveness of the lesion, the involvement of the lesion. So all the times are not very clearly understood that what could be the right here. So when there is a history of hematuria, that is very important that we should be able to scan the entire urinary tract.
Right.
Maybe it is very convenient to use the ultrasound if the ultrasound is available in the OPD or in the hands of the doctor himself. It is urologist operated or surgeon operated ultrasound is very quick assessment. Sometimes the clots are very important. Many times the clots are usually smaller in cases of bladder cancer, but it could be a very big clot, and even the patient may present with retention of urine because of the clot retention. The presentation of the upper tract urothelial cancer is little different. Many times they are associated with clot colic, and many times the people are passing clot-like threads. This is very typical of urinary cancer. And renal cancer can have a uniform mixed blood mixed urine, but sometimes there could be huge bleeding and there could be clot retention even. So all these things makes little confused. So the diagnosis on history is not enough. We would have to evaluate further and further until we get correct information, correct decision making data. So thank you very much, sir.
Thank you, sir. Thank you, sir. Will you ask any question to Dr. Amina, Professor Salam, for further approach and investigations? Sir, can you hear me?
If you ask me to investigate this particular patient, then
No,
I
sir.
will.
You will ask question to Dr. Amina what she want to do.
Oh, I see.
Yeah.
That's a good.
Yes.
Madam, how do you like to evaluate this, this particular patient?
And thank you, sir. At first, I would like to do some baseline investigations like complete blood count, urine, routine examination of the urine army. And then I would
What
also...
you can expect in routine examination of urine?
There will be RBC, and there
No,
can
just
also...
give me a correct answer. What you can get out of the routine examination of the urine in this particular case for with the aim of diagnosis?
There can be, sir, as there is gross hematuria, there can also be presence of pus cell, which we can tell if there is any associated urinary tract infection, and passage of RBC will also say already we can.
Pus cell does not make.
Yes.
Please listen to me. The presence of pus cell does not give you an information that he is having or she is having a infection. Urinary infection or any infection should be diagnosed along with the clinical manifestation of the infection, means the fever. Unless there is any fever, it is difficult to understand that he has got a significant infection anywhere. So that is also not very good examination.
Okay.
So
Sir,
your urine examination is not going to help you.
Then I would like to do an ultrasound of whole abdomen.
So this is your baseline investigation.
You should be able to suggest a list of investigation that has to be done immediately to make a confident diagnosis. That may include your imaging with ultrasound or CT scan. If the renal function is known, then you can ask for a contrast enhanced CT scan, which can give you a lot of informations. The ultrasound will not be able to provide those informations. Do you like to do a PET CT if it is available here?
No, sir, not at first. I would like to do a contrast enhanced CT scan at first. That will give me an idea about the site of the lesion, and also associated. It will help me in staging also. Staging in the abdomen, it will help me too. And after doing
CT scan is very cheap investigation, but people are interested to do more expensive investigation. Why you?
So for our students, can you hear me, sir?
Selecting this
Sorry, sir, the line is not clear. We cannot hear you.
So
When Sarul-
these are the issues which are seen in the clinical MRI scan. Do you hear me?
now,
Sir.
now we can hear.
Are you here?
Now we can hear, sir.
Okay.
So,
So-
as Dr. Amina says, first she want to do an ultrasound scan. So, do you agree?
I think I will agree because this.
Yes, sir. Yes. So, this is your ultrasound scan, Dr. Amina.
Give a rough estimation, but this on the basis of this ultrasound, I will not be able to tell everything.
Yes, this is your ultrasound report. Can you see, read the comment?
Yes, sir. In the comment, it says slightly thick, irregular urinary bladder walls and swollen hypoechoic right kidney, renal architecture, and could not be outlined.
What is your impression now? From your-
There can be another it seems like a renal mass, renal neoplasm.
renal neoplasm. Professor Sudhir,
Yeah, and
Yeah, actually, since ultrasound is not very informative and
Yes.
it says swollen hypoechoic right kidney, renal artery not outlined. So I probably will go for CT scan.
see contrast enhanced CT scan
Yes,
of colon.
CT. Yeah.
CT scan. So this is the CT scan, and there is the images is like this.
Yeah.
So just to save the time, can you read the impression?
The impression is suggestive of right renal mass with tumor thrombus within the right renal vein in the inferior vena cava, possibly right renal cell carcinoma and non-functioning right kidney.
You need to tell the extent of thrombus. Is
Thrombus.
going to IVC or not going to IVC?
Within the right renal, it says within the
IVC.
Sir, the lesion extends up to the renal pelvis, and that tumor embolus it is thrombus is visible extending a part of infradiaphragmatic part of inferior vena cava.
Yeah, there's the.
Yes.
I'm in a meeting.
Yes, sir. So what next?
Then, as it says, it has involved the inferior vena cava. I would like to do a CT angiography to see CT angiogram. We can do a CT angiography.
I don't have all the images, but the few images of this patient is with me, like this one.
Yes, sir. There is it is seen that there is a hypodense lesion in the right kidney with a rim of cortex can be seen, and there is a lesion in the pelvis of the pelvis of the kidneys, and probably it may have and there is a filling defect can be seen in the right renal vein, and it's not that clear that much to me, sir. I have some confusions in this.
Okay, then. Sir, will you make any comment?
Oh, the single renal artery on the right side.
Yes,
And
sir.
rest, I agree with her. We can't make more because probably we'll need more images.
Images, right.
Yeah.
Right. So what next, Dr. Amina?
So as it also could not delineate, we can also do an MR venography if it can give us any other information.
what specific information MRI will give you in this patient?
Sir, actually CT angiography and MR angiography both will be equal in diagnosis in the inferior vena cava thrombus. I don't think that will help that much.
No, it will give you one information, that is if the tumor thrombus is involving the renal IVC wall. That MRI gives better information than CT scan.
Okay, sir. Yes, sir. Then we will have to do an MR angiography to see the involvements better.
Then you can do that, but if you are planning surgery, probably you may not need to do that, because then you will come to know anyway. But it is there, like one kind for discussion. MRI gives the extra information of wall involvement of IVC. Otherwise, rest everything you can see on CT and CT angiography.
Equal, yes. Okay, sir.
So what is your plan now?
Now, as we will have to go for other staging investigations, like we can do a CT scan of chest and pelvis also, and we can do liver function tests, serum alkaline phosphatase to see to complete our staging investigation. And then we will have to approach the patient in a multidisciplinary approach for further decision.
Okay, good. So what do you suggest about this metastatic workup? Which investigations?
Yes, sir.
About metastatic workup, which investigation you advise?
Metastatic workup, we will do a chest CT scan, chest, abdomen, pelvis, and chest and pelvis, and also we would like to do a liver function test and also alkaline phosphatase. And if he does not have any bone pain or any symptoms, so that's why I didn't include the bone scan here.
Okay.
Even then you can involve, you can see the bone scan.
Okay, sir.
Okay, thank you, sir.
Thank you, sir.
What do you suggest?
Do you, I think you guys have PET scan, FDG PET scan, or PSMA PET there in Bangladesh, Dhaka?
Yeah,
Or
yeah,
Chattagam?
we have, sir. We have PET scan.
What do you think about PET scan in this case?
Sir, if there is we actually, I don't think he needs a PET scan if it is equivocal finding in any of the metastatic workup, then I will go for PET scan.
Yeah, that's great.
Okay, sir. Next history, probably Dr. Amina don't know, but about that patient, what happened? Patient had a radical nephrectomy on the right side and subjected to histopathology. And this is the histopathology reports.
Yeah, yes, sir.
Professor Salam. Sir, will you make comment? Can you hear me, sir? Sir, you are muted, sir. Professor Salam, you are muted. You are muted.
Yes,
Yes, sir. Now we can.
you can hear me.
Yes, sir.
This is a urothelial carcinoma. This is very interesting to understand. Urothelial carcinoma, this is a squamous differentiation. Obviously, this belongs to a very high grade. It has invaded into the renal parenchyma. Lymphovascular invasion is present, which is also a very important observation. Lymphovascular invasion always tells us that the outcome of the patient will be very poor. So
what about thrombus? the thrombus was removed. It's very rare to see thrombus in
Yes, that is very
urothelial.
interesting. The
Yeah.
thrombus with
Urothelial is
TCC or urothelial carcinoma is not very common. Most common is clear cell carcinoma or the
Yes.
RCC.
and was
These
the
things
thrombus removed?
makes
What is this?
a great discussion and because the treatment of the urothelial carcinoma is entirely different when it involves the upper tract. The entire ureter has to be removed along with the sleeve of the bladder.
Yeah.
It was not been understood before, and as a result, a radical nephrectomy is performed. But it has to be performed now, and evaluation with the cystoscopy is also very important in these particular cases. That can be done later on.
Okay, sir. Any comment? Any more comment?
I think a very simple urine cytology could be a very important investigation in this particular case. Maybe that will be a game-changing investigations. That is a very important point I'd like to make. And sometimes it is very confusing and difficult to differentiate the RCC and the upper tract TCC if it involves a single calyx or two calyx or in the major calyxes. Sometimes it is very difficult, but a high index of suspicion will make you a diagnosis of TCC in those cases. Nowadays, it is it may be reasonable to refer these particular patient where there is possibility of seeing the entire pelvis, and even the calyceal biopsy can also be performed with the ureterorenoscope.
Yes, sir. Actually, this was done in a peripheral hospital, periphery.
Yeah, I know.
But we didn't have that much information.
Even in the advanced hospital, it can happen. So
Actually,
this presentation is not uncommon. It is fairly common. I
actually,
hope, Sudhir, my dear friend,
Yes,
do you
sir.
see these cases in your practice?
Yeah, it does happen. I agree with you.
Yes.
It can happen anywhere.
Yes.
Yeah, it does happen.
The question Sudhir asked about this, what about this thrombus? But we didn't have that much information about what the paramedic findings at that moment. Actually, we don't know. But only I have the information the patient had the radical nephrectomy and the total histopathological report as I presented here. The urothelial carcinoma squamous differentiation high grade. Okay, then. So what would be the advice for this patient now, sir?
I'll add adjuvant therapy, especially chemotherapy for him, because high grade invading the renal parenchyma. And later on, as Dr. Salam said, that ureter with the cuff has to come out. That can be delayed for later on, but he does require adjuvant chemotherapy, gemcitabine and cisplatinum if possible, otherwise gem carbo.
Okay, then thank you, sir. Dr. Kamal.
Sir, I have a question. It said that the ureteric margin was clear. So still we will have to resect the cuff of bladder too?
Yes.
Okay, sir.
Because the urothelial carcinoma, they are multifocal and they have very high chances of reoccurrence in the stump and even in the bladder. There are 40% chances that patient will fail in the bladder. So they have, when they come for follow-up, one has to do the cystoscopy in these patients of upper tract.
Dr.
Thank you.
Just to add that the patient should be on follow-up and systemic cystoscopy and yearly a CT scan with contrast is a recommended investigation. every 3 months the patient should have cystoscopy. You may be surprised to see that there are recurrences in the bladder.
Yeah.
In those cases, you will be obliged to take out the tumor and put the patient on BCG therapy if it is high grade. So follow-up is very much important. Even it is possible that the remaining kidney can have this upper tract urothelial carcinoma. That is one of the reasons that we have to advise a serial ultrasound, and also, if suspicion, he should have a contrast enhanced CT scan of the abdomen to visualize any lymph node or anything which is abnormal, and also the other kidney. Out of surprise, you may see that there is occurrence of the tumor in the other side as well.
Sir, you are in mute, sir. Ajad, sir.
Okay. One investigation at the time at the periphery when a patient developed a clot retention. At that time, patient had a cystoscopy. There is a few findings on the cystoscopy. Sorry, not this one. Which one? This one. This one is the ureterocystoscopy finding. This
Good. Very good. So no tumor was that. That is the most important point.
But in the bladder, this is another important point. Thank you, sir.
Yeah.
Dr. Kamal, have you joined?
Yes, sir.
Yes. So we need your opinion.
May I have the question, please?
Yes, sure. Sure, Kamal.
Because I just joined.
Yes, Professor Rawal has joined.
Yeah. Good evening, Dr. Kamal.
Good evening, sir. How are you?
I'm fine. And how are you all?
We are fine. So this September, no chance of any overlap, sir.
Okay. Sure.
Please tell us the date. September 11, 12,
14, 15. 14, 15, sir.
Okay.
Yeah, I already have.
14, 15.
So, Kamal, this is the patient who had initially suspected as a renal tumor, and then patient underwent a radical nephrectomy, and the subsequent histopathology revealed it was a urothelial cancer with squamous differentiation, high grade, LVI present and PNI present. So this is the present scenario of this patient.
So unfortunately, as it became our TCC, so we need to do extensive search metastatic workup.
Okay.
Because we know that there is a big chance of metastasis in the lung. So we do the CT scan of the chest with contrast. And also, I will prefer to do a bone scan also because there is a chance of bone metastasis also. And if there is no metastasis, then we will go for adjuvant chemotherapy for this patient. And I will counsel the patient that the T3 N0 NXMX, if it was RCC, the chance was quite high to have a good survival, but in TCC, even with non-metastatic, there is a high chance of recurrence.
Okay,
normally, we give gentamicin cisplatin-based chemotherapy.
Thank you. Thank you very much. Now, a question. Dr. Saiful, any question in the chat box? Dr. Saiful, can you hear me? From the students? Dr.
Sir,
Saiful?
I have some questions. Sir, I have some questions, sir.
Sure, sure.
Sir, is there any chance of invasion in the aorta? Here, CT angiogram shows that a thrombosis in the vena cava. Is there any chance of invasion of the tumor in the aorta?
Professor Salam, sir.
Sir, I couldn't understand your question properly. You are talking about the invasion of the aorta, is that correct?
Yes, sir. CT scan shows that the tumor invaded into the inferior vena cava, that is thrombosis. Is there a such immune invasion into the aorta?
It doesn't happen in that way.
In that
Usually,
way.
venous thrombosis is a very special character for the RCC, and also in some cases of Wilms tumor, and also very rarely the TCC. Usually, the thrombosis that proceeds along with the vein, and they used to proceed gradually over the time. They go into the inferior vena cava, first the renal vein, then they invade the renal, the inferior vena cava, and gradually the tumor progresses and they can ascend up to the right atrium. Many times the hepatic veins are being obstructed. I had an opportunity to work on these such cases where the patient was having very high bilirubin and also congestion of the liver. In that particular case, we have removed the entire thrombus after having putting the patient in the cardiac operating theater, and we have done a atrial opening, and through the atrium we could access into the entire venous thrombus, which was removed, and during the process we have removed the hepatic thrombus as well, hepatic vein thrombus. So there, all the three hepatic veins were full of thrombus, and as soon as we have removed, the congestion of the liver has been regressed to a normal level. And
thank you, sir. Sir, another question, sir. For thrombus removal, how much vena cava involvement will allow for the removal? 30% of the inferior vena cava, or 50% of the inferior vena cava, or less than 30% of the thrombus of the inferior vena cava? How much involvement of the inferior vena cava will allow to remove the thrombus?
The vena cava thrombus is usually classified into level 1, level 2, level 3, and level 4 level. Level 4 is the atrial thrombus, if it ascends up to the right atrium, and level 1 is only subdiaphragmatic, so subhepatic. So if it is subhepatic, it can be easily controlled with a abdominal incision, and without any help of hepatic surgeon or vascular surgeon or cardiac surgeon, you can remove the entire thrombus, and you can have a en-bloc resection of the tumor. So that will give you almost a benefit of radical surgery. It means 5-year survival rate may go to up to 93%. But
Yes, sir.
What about level 2 and 3, sir?
yes, sir. Can you repeat the question?
So you have said about level 1 and level 4. What about level 2 and level 3?
If it is inside the hepatic vein, obviously you would have to mobilize the liver, and maybe in certain cases you may be pulled down if the patient is not, if the thrombus is not invading. If it is a clotting thrombus, it will come out without any difficulties. But if it is invaded, in that cases, the assistance or collaboration with the vascular surgeon, hepatic surgeon, and cardiac surgeon all are required. So it should be performed in a center where all the facilities are available. I hope Dr. Sudhir Rawal have got such facilities. I know many of the cancer centers like Sloan Kettering Memorial Center doesn't have these facilities. So they don't treat these cases. Even Tata Memorial Center I have asked that whether you are able to do it or not. They said that we can't do it because we don't have any cardiac surgery unit. Sudhir Rawal will agree to it. He is a capable surgeon. He will be able to manage these cases in his own hospital. Is that correct?
We do have a cardiac surgeon on visit.
Oh, I see. Then you can do
and
it.
we are actually, but till now, I will be very honest, I take these patients to Gangaram and I operate myself always. I have done around more than 10 of such cases.
Good.
And we put it in a cardiac theater, cardiac surgeon is there, and we put in a deep hypothermic circulatory arrest. Reversal is very smooth. You get half an hour, bloodless field, whole of the blood is outside body,
Yes,
and
absolutely.
you can operate, and it's very safe nowadays. So you elaborated everything about IVC thrombus, and somebody asked how much IVC you can sacrifice. You can infra-renal IVC up to the common hepatic vein, common iliac vein, you can sacrifice without any problem.
Replace it with a graft.
Yeah, even on the right side tumor, left renal vein can be ligated at the insertion, and you can take out the IVC also. But if the lumen is there, then even 30% of the lumen is enough. If suppose IVC, the tumor thrombus is involving the IVC wall, even you can take out the IVC wall and reconstruct sometime. Sometime you can just repair the vein, sometime you can excise, depending on the situation.
Thank you, sir.
Sir, another question, sir. If the tumor engages the IVC or aorta, what is the treatment modality? If the renal mass engages the IVC or aorta, what will be the surgical option?
I think why, Mane, you are thinking so much about the aorta here.
Aorta, it doesn't invade.
Don't think about the aorta, Dr. Sadi.
Encasement, sir, encasement.
Yes, don't think about the aorta. So encasement, I think patient will not survive anymore.
Let me answer this question. He is asking a question that if a patient is having an invasion into the inferior vena cava and also have got a local metastasis in the region, what could be the survival outcome? So in these particular cases, if you resect in toto and block resection is possible without leaving a leaving tumor behind, the outcome may be good as it has been said that if you can remove the thrombus entirely along with the tumor, then it will produce an effect of radical nephrectomy in these particular cases. It means they can survive for a long time.
Thank you, sir. Thank you, sir.
Okay, then thank you, sir. Now it's time